All right, welcome. This explainer is for all of you, the next generation of emergency nurses. Today, we're going to build a toolkit, something to help you not just survive the chaos of the ER, but to actually lead change in what's got to be one of the most dynamic environments in all of healthcare. So let's start with this kind of weird paradox. Think about it. In the ER, your entire job is reacting to crazy, unexpected change, right? Every single second. But then, management comes along with some planned change, like a new charting system or a different way to triage patients, and suddenly it hits this massive wall of resistance. Why is that? What is going on? Well, if you want to be someone who can actually lead change, first you have to get a handle on why people push back. And I mean all of us. It's just human nature. It's not about being difficult, it's all about psychology. Okay, so let's break down what's happening under the surface here. First up, there's the threatened self-interest. You hear about a new AI system for patient assessment, and you're thinking, wait, are they trying to replace my clinical judgment? And then there's just the fact that it's easier not to change. You've got your routines, your rhythm that works under pressure, and messing with that just feels risky. Of course, change always brings uncertainty. Is this new protocol really going to be better, or is it just going to cause chaos during a code? And a lot of the time, nobody really explains why the change is happening in the first place. In a place like the ER where you rely on your team, it can totally upset those relationships you've built. And finally, and this one's a big one, there's that fear of failure. You're great at the old way. What if you can't get the hang of this new tech as fast as everyone else? And yeah, this quote here really just nails it. It's not about learning a new button to click. It's about threatening the security, the patterns we have come to rely on to get through a really, really stressful job. And getting that, really understanding that and having empathy for it, that's the absolute first step to being able to lead anyone through a change. Okay, so let's shift gears a little bit. We need to talk about the fact that not all change is created equal. As a nurse, especially as a leader, you're going to run into two totally different kinds of change, and knowing the difference is, well, it's crucial.
So on one hand, you've got planned change. This is the good stuff. Think of it like a super smooth trauma response, where everyone knows their job. It's strategic, it's deliberate, that's what we're aiming for. But then, you've got the other kind, accidental change. Some people call it change by drift. Honestly, it's like an organizational multi-car pileup. It's just chaotic, it's reactive, and it causes so much unnecessary stress. Your job, as a future leader, is to be the one steering the ship, not just getting tossed around by the waves.
Okay, so how do we make sure we're doing the planned, effective kind of change? Well, the good news is we have a playbook for this. A guy named Kurt Lewin, a social psychologist, came up with a method way back when that is still, it's incredibly relevant for anyone in healthcare leadership today. So Lewin gave us 4 basic rules. Rule number 1, you've got to have a good reason. You change to solve a problem or make things more efficient, not just 'cause. Rule 2, you have to expect resistance. It's going to happen. It's not a sign you're failing, it's just part of the deal. 3, go gradual. Don't just drop a massive change on everyone all at once. Give people time to adapt. And number 4, and this one is probably the most important one of all, you have to involve the people who are actually affected by the change. Get them in on the planning.
So, if you follow those rules, the whole process breaks down into a really clear 3-stage model, and it's something you can use for pretty much any change you ever try to lead.
And those 3 stages are planning, implementation, and evaluation. Super simple, right? But you would be shocked at how often people skip right over the planning part and jump straight to implementation. That's a recipe for disaster. So let's really focus on that critical first step, the planning.
Okay, when you're in that planning phase, you're basically juggling 3 big things. First, there's the people. You got to think, what are my colleagues' attitudes going to be? How am I going to explain why this is a good thing? Then you have the structure. Does this new protocol even line up with hospital policy? Who has to approve this? And finally, you have technology. That new charting software, is it even compatible with the tablets we already have? A really solid plan hits all 3 of these right from the get-go.
But here's where Lewin was really a genius. He knew this wasn't just about project plans and checklists. He mapped his whole theory onto the psychological journey that real people go through during a change. It's about leading humans, right? Not just managing a process. And that journey has 3 phases.
So phase 1 is called unfreezing. Think of it like this. Everything's frozen in place, right? The old way of doing things is solid. Your job as a leader is to turn up the heat a little. You help your colleagues see that the old way isn't really cutting it anymore. You're creating that motivation for change by showing them, hey, here's a problem we really need to solve.
Then you get to the movement phase. This is the action part. This is when you actually introduce the new protocol. And as the change agent, you have two jobs. You have to be the cheerleader for the driving forces, constantly reminding everyone, hey, this is going to reduce med errors. This will get patients admitted faster. And at the same time, you have to tackle the restraining forces, the things holding you back. Like, you notice some folks are struggling with the new software, so you get them extra training. You're pushing and pulling at the same time. And last but not least, you have refreezing. This step is so important, but it's often forgotten. This is where you make the change permanent. You stabilize the new system, lock it in. So it just becomes the new way we do things around here, the new normal. If you skip this, people will almost always drift right back to the old comfortable way. So, what's the big takeaway here? All this theory, it's not just for some hospital administrator in an office somewhere. This is for you. You're on the front lines. You see the problems firsthand. That puts you in the absolute perfect position to spot what needs fixing and to lead the way. Look, as you start your career in the ER, you're not just going to be a victim of change. You're not just going to be reacting to it. You are going to be a change agent. Whether it's a tiny little tweak to how you stock a supply cart or a huge department-wide initiative, you have the power to make things better for your team and, most importantly, for your patients.
And that's really what I want to leave you with. As you go through your classes, as you do your clinicals, start using this toolkit. Start looking around not just at what is, but at what could be. And start asking yourself that question. What's the first positive change you're going to lead?